Well, it's really answers an unmet need. 1.2 million people will develop gastric and die of gastric and esophageal adenocarcinoma worldwide. And for early stage disease, we have not had a major breakthrough in management of cancer recurrence and reducing the risk of cancer recurrence when it comes to targeted therapies. So MATTERHORN is really the first perioperative study, by perioperative meaning neoadjuvant and an adjuvant therapy, to show that immunotherapy can improve survival in those patients. So the global impact of this disease and the fact that it was truly a randomized phase 3 placebo-controlled, very robustly conducted first study of its kind in such a comprehensive, difficult to treat disease, I think was probably the reason why I was selected for the plenary, but also given the data robustness published in New England Journal of Medicine. Yes, so there were two phase 3 studies just in the past year, both published in New England Journal of Medicine, solidifying the position of FLOT as the preferred regimen for a perioperative setting. And historically, at least in the United States, some individuals with adenocarcinoma would get chemoradiation, the so-called cross regimen. Now we have solid level 1 evidence that FLOT is the preferred approach. So the timing of the publication of MATTERHORN was very much, accepted because of that reason, and it was perfect timing. We know that immunotherapy works in metastatic disease. We know that we've been able to combine immunotherapy with chemotherapy, and many of these agents, anti-PD-1 targeted agents, are approved in metastatic setting. So to be able to bring a similar agent, anti-PD-L1, durvalumab, to early stage disease really was an important opportunity. Of course, MATTERHORN is level 1 evidence positive study. I think we know that immunotherapy works, particularly in advanced tumors. I think everyone was excited to see that the MATTERHORN was positive, especially since previously to that, Keynote 585 missed the mark. And a lot of the discussion around the MATTERHORN data showing that event-free survival is improved, pathologic complete response rate is improved, disease-free survival rate is improved, check, 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 and overall survival appears to be trending positive. Was exciting because, as we know, a different regimen, a less modern regimen, a doublet cisplatin-based regimen in 585 missed the mark in combination with pembrolizumab. It's an important point to bring up because feasibility and safety is the first paramount, right? Endpoint to demonstrate. And often, especially the surgeons and certainly the patients and oncologists, are worried about compromising the chances of cure. And we never want to compromise that in early stage disease. What we demonstrated is the delivery of perioperative therapy was excellent, close to 100% in both groups, the placebo and the durvalumab group. FLOT delivery was great. The R0 resection rate was identical, so we did not compromise likelihood of complete resection or surgery. And then most patients were able to complete adjuvant therapy as well, so more than half of them. It's a great step forward for this disease because that means we can unify the approach across the continent. Over 4, patients from 4 different continents were enrolled to the study, and move forward as a group, as a field. I think it's important because these patients can be quite frail nutritionally, and to be able to say that we can give FLOT even in individuals who are greater than age 65. In fact, if you look at baseline patient characteristics, there were some octogenarians in the study, enrolled in the study, patients in their 80s. So the modern approach is FLOT. the patients and the clinicians and the surgeons, everyone is accepting it. And most importantly, the placebo arm in our study actually outperformed the historical FLOT data. So despite the fact that the control arm outperformed what you would expect with the FLOT in general from prior years, we still were able to beat it with the addition of durvalumab and demonstrate the benefit. And it's good news for our patients. It means that the clinicians and the cancer staff know how to take care of gastric cancer better and know how to give FLOT. There is a lot of data that's still forthcoming, and we have it, and we'll be presenting it at further congresses, including the biomarker data. In-depth biomarker plan for this study is to have baseline and on-treatment samples analyzed, to have patients' peripheral blood analyzed for presence of the T-cell clones that are expanding, for circulating tumor DNA and MRD monitoring. That data will be a treasure trove of information to help personalize some of these decisions, particularly how long should a patient stay on adjuvant therapy. The disease-free survival is improved with this regimen, meaning that even in patients who had a complete resection and were cured, there's still a reduction of cancer recurrence based on disease-free survival for adjuvant therapy. So to have these personalized, biomarkers, we will need to have more data. But I can tell you now is in each pre-specified subgroup, protocol pre-specified subgroup, typically tumor location, histology, PD-L1 overexpression, the geographic location of the patient, age, all of those pre-specified subgroups benefited addition of durvalumab. So there's a treatment effect in every patient. And particularly for PD-L1 expressing tumors, there's a benefit, but so are the PD-L1 negative. The PD-L1 negative cohort is very rare. It's 10% of the population. And even though in those patients, the hazard ratio favored addition of durvalumab. Goes to show that we need to do more biomarker selection if we're going to understand, because PD-L1 is probably not the answer for these patients. Well, most regulatory bodies look at the primary endpoint, and the primary endpoint, and this is the final analysis, is event-free survival, and it's strongly positive. And then the next step is to look, does the totality of the data support that, right? So if you have primary endpoint that's positive and the rest of the data, including pathologic complete response, disease-free survival, which are also, final, and overall survival all supported, I think it makes the decision for regulatory authorities pretty easy. The OS in this cohort is not final, and it's a secondary endpoint, but certainly seeing the separation of the survival curves and the plateau on the OS curve is very promising. So I think it's overall going to be favorably reviewed.